As my first slide hinted, part of what I want to do is introduce the idea of adjuvant or co-analgesic agents for pain control. And this takes us back to 1986 when the World Health Organization introduced something called the analgesic ladder approach for managing cancer pain specifically. Basically, it links the use of different analgesic medications to the level of cancer pain. It also specifically introduced the idea of using selected agents such as corticosteroids, some anticonvulsants, some psychotropic agents as adjuvant or co-analgesic agents in order to improve patient responses. Starting at the level of mild pain, the pain can be controlled most effectively by the use of a non-opioid agent, an NSAID, acetaminophen, or one of the adjuvant agents. As pain persists or increases, you may add a weak opioid. As pain goes further, you would branch out to a strong opioid. Again, at all of these steps, you would include the non-opioid or an adjuvant agent. Recently, this analgesic ladder has been modified to recognize that you can also use non-pharmacologic drug therapies in addition to the drugs, and it's not always an ascending ladder. In other words, you can step down as needed when pain is being controlled. Now, specifically, the adjuvant or co-analgesic agents are agents that were originally developed for indications other than pain. But in certain painful conditions, they can provide some analgesic efficacy. Currently, that term generally also includes both the nonsteroidal anti-inflammatory agents and acetaminophen. The advantages of using the analgesic ladder and introducing adjuvant agents are that using them concurrently with an opioid will not only boost the efficacy of the pain relief provided by the opioid, but it often allows you to reduce the opioid dosage, that is, they're opioid sparing, or they can target a specific kind of painful condition where the opioid may not be as fully effective as it might be in another acute painful situation. You've undoubtedly heard a lot about opioid agents like morphine and fentanyl. We'll discuss what is currently called the opioid crisis separately in later lectures, but I imagine you know that opioid drugs are quite effective in relieving acute pain. That's true, absolutely true, and no one, neither you nor your patients, wants to be in pain. So, why are we concerned with non-opioid agents? To answer that, we'll need to consider differences between acute and chronic, particularly chronic non-cancer related pain, and the impact that the opioid crisis is having on our society. One example is a high-impact meta-analysis paper in late 2018 in which opioids were shown to produce only small benefits to pain and physical functioning in patients who had chronic non-cancer related pain. In that study, prescription opioids versus placebo provided meaningful pain relief to only 1 in 8 patients and caused harm, specifically an increased risk of vomiting compared to placebo. We know also that opioid use is associated with the development of hyperalgesia in some circumstances, with addiction and diversion, with morbidity, and with mortality. Of all patients prescribed long-term opioid therapy, development of tolerance and physical dependence is certain. Over 25% engage in non-medical use of their opioids, and an estimated 8 to 12% will show signs of addiction. And then significantly in the 2018 paper, Non-opioid alternatives were shown to be as effective as opioids in benefit for pain and functioning. All compelling arguments for the use of non-opioid analgesics. As my first slide hinted, part of what I want to do is to introduce the idea of adjuvant or co-analgesic agents for pain control. This takes us back to 1986 when the World Health Organization introduced something called the analgesic ladder approach to manage cancer pain. And basically, the analgesic ladder links the use of different analgesic medications to the level of cancer pain. It also specifically introduces the idea of using selected agents, corticosteroids, anticonvulsants, and psychotropics, as adjuvant or co-analgesic agents in order to improve patient response. Since that time, the latter has been used extensively and modified in several significant ways. For example, it now includes the use of non-pharmacologic therapies, particularly in early or milder levels of cancer pain. And it also allows for step down. So as pain is well controlled in a patient, you may be able to reduce the level of opioids that are being prescribed or make other modifications as necessary to maintain analgesic efficacy, but simplify the therapy for the patient. The adjuvant or co-analgesic agents are drugs that were originally developed for indications other than pain, but which can provide analgesic efficacy in specific painful conditions. Currently, we kind of lump together the nonsteroidal anti-inflammatory agents and acetaminophen into this group of adjuvant therapies. The advantages of taking this approach are that the use of an adjuvant and analgesic in addition to an opioid will tend to boost the efficacy of the analgesic effect produced by the opioid. It tends to allow you to reduce the opioid dosage that's needed, that is, they're opioid sparing, and it can allow you to target specific kinds of painful conditions other than cancer pain that may not be as amenable to analgesic relief with an opioid as acute pain may be. So, in managing any kind of pain, the type and source of pain should help differentiate the approach. The concept of using adjuvant co-analgesic agents has been expanded and is now considered as implementation of something called multimodal analgesia, or MMA. The algorithm here is simply one example. It suggests how to approach treating an individual with chronic non-cancer pain specifically. You are not responsible for the specifics of that flow diagram. This is also a good place, however, to emphasize the variety of clinical situations in which multimodal analgesia and the use of adjuvant or co-analgesic agents can help in pain control. This gamut runs from acute trauma, peri and post-operative pain, to cancer pain and chronic non-cancer pain. We'll look at greater detail in this and in subsequent sessions. Thank you.